Thank you. Um, again, I'm Brayden Chamberlain. I'm one of the current third year residents at Full Circle Health, formerly the FMRI. And it is my uh, intention to discuss with you today the topic that you see before you, mainly children and adolescents with obesity. I'm going to be focusing on the evaluation, interventions, and the evidence behind those things. Um, and before we get into that, let me see if this, okay, good. A couple disclosures. Um, this is a presentation that I don't have any financial involvement with. None of the, uh, there's no financial incentive for this. And I believe you can get some CME credit for this as well. So make sure to do that. Um, Again, no financial relationships here. And most of the information I'm going to discuss comes directly from or is related to the AAP's first clinical practice guideline on the evaluation and treatment of children with children and adolescents with overweight and obesity. Um, Most of these recommendations are evidence-based, though I will say a few of them are expert opinion only. And just a note here, this guideline doesn't cover the prevention of obesity, only the treatment of it. And here you can see a little screenshot of the headline of that clinical practice guideline. As you can see, this was put out the first of last year. So almost 2 years old now, but the things discussed in it are still all largely up to date and recommend you read through it. There's also a kind of a bullet point, a summary version of this. You can read in detail everything that they went through, but you can also read their bullet points if you'd like. I'm going to be hitting on the key parts of this guideline and focusing a little bit more on some of their more, how would I say it, interesting or new recommendations. So, our objectives for today, first, we're going to review some of the definitions of obesity in children and kind of the importance of that clinically and statistically. Then I'll review some of the current evidence and recommendations regarding the evaluation and interventions for childhood obesity. And I'll also throw in here and there a little bit of the evidence for screening for comorbidities in that population as well. So, first off, the definitions. Overweight and obesity. In children, overweight is defined as a BMI at or above the 85th percentile and below the 95th percentile for someone of that same age. Obesity is defined as BMI at or above the 95th percentile for children or adolescents of the same age. And then you can further classify that into severe obesity. Severe obesity is defined as a BMI greater than 120% of the 95th percentile for those same age range and sex. And then that can get classified a little further. You can get class 2 severe obesity and class 3 severe obesity. Class 2 is between 120 and 140%, or 35 to 40 BMI. And class 3 is greater than 140% or greater than 40 BMI. With those definitions in mind, I also want to point out, and this is something that they go through in the guideline themselves, they recommend using person-first language especially when talking with children with obesity. And what they mean by that is focusing on the individual and not on their disabilities or their conditions. So in this case, that would be children with obesity or adolescents with obesity or overweight, not obese children or obese adolescents. That makes this more of an adjective rather than a condition that they're dealing with. So along those same lines, I want to get into the history of obesity a little bit before we talk about why we should be considering things maybe a little bit differently than we have in the past. So, obesity has long been stigmatized as a reversible consequence of personal choices. Um, there's been many derisive adjectives applied to people with obesity, such as laziness, they're lacking self-control. Um, I'm sure you can think of much worse descriptors that have been applied to people with obesity. And a lot of the focus has been on the individual's lifestyle. Now, while the lifestyle definitely plays a significant role in obesity, ongoing research shows that obesity is definitely a complex condition resulting from genetic. Oh, hold on one second. Something popped up on my screen. Okay. Um, has genetic, physiologic, socioeconomic, and environmental contributors. And in particular in children, even probably even more so than in adults, social determinants of health play a large role. We see that children who are exposed to racism, poverty, adverse childhood experiences, or other types of stigma or discrimination are more likely to be obese or to experience obesity than children without these exposures. And to give you kind of a setting here, the percentage of US children affected by obesity has tripled since the 60s, from 5% to around 20% in 2017, 2018. And they do note that the rise has slowed a little bit since then, but it has still continued to go up. And then they also note that if the trend holds, 57% of children aged 2 to 19 will have obesity by the time they're 35. So a lot of people, even that's suggesting that they would increase from 20% of the population at that age to 60% of the population would become obese. Um, and how does that compare to the rest of the world? Well, on sheer numbers, China leads with 28 million, 28 million children that are in the obese category. The United States is second with 13 million, and India with 7.5, and you can see on down the list. However, China, with a much higher population, their prevalence is actually around 11.7%, somewhat in the average range for the world. And when you compare prevalence or percentage of children, the highest are found in the Pacific islands, and then the only one that's not in the Pacific Islands is the United States. All of these with the prevalence of at or more than 20%. So, so what's changed since the 60s? While we shouldn't focus solely on lifestyle, as I just mentioned, there's no doubt that lifestyle does play a huge role in obesity and weight gain on a population scale. And in particular with children, there's been a big change in lifestyle since the 60s. Three big things that have been noticed: increase in technology use, decrease in physical activity, and a change in where they get their nutrition. So, um, nutrition previously, a lot of home cooked meals, less processed foods. Obviously, that's all switched a lot, and we see a lot more of those things nowadays. Um, what does this result in? What's the impact from this? Well, we can see that this doesn't just affect children, because children with obesity commonly become adults and adolescents with obesity. And the same is true with severe obesity. So people with severe obesity, they end up being severely obese as they get older. Um, Obesity puts children and adolescents and later adults at risk for adverse health outcomes, including cardiovascular disease, hypertension, um, dyslipidemia, insulin resistance, diabetes, liver dysfunction. Um, And on top of all those um, physical uh, maladies, obesity in adolescence in particular, and even into adulthood, is associated with poor psychological and emotional health. So you increase stress, you increase depressive symptoms, and you lower self-esteem. All of those have a substantial impact on the individual, and they in turn actually can worsen the obesity. It ends up becoming a very vicious cycle that is overall detrimental to the person's health. And all of this can start in childhood. So, with all of that in mind, because obesity is a chronic disease with escalating effects over time, the AAP is recommending a life course approach to identification and treatment, meaning begin as early as possible to monitor and treat this condition. You should continue longitudinally through childhood, adolescence, young adulthood, and in adult care. So that's kind of the basis of where we're going with this new guideline. Viewing obesity as a lifelong condition that should be managed as early as you can. I'm going to talk briefly about screening for some comorbidities that they recommend in the guideline. As part of their specific, I think their key action statements, they recommend these screening guidelines. So in children that are 10 years old or older with obesity, they recommend screening for liver dysfunction plus lipid and glucose abnormalities. In children who are 2 to 9 years old with obesity, or if they're 10 and overweight, you might consider screening for lipid abnormalities. And they don't necessarily recommend universal screening for liver or glucose abnormalities. They recommend only doing so if there's other risk factors for that. That being said, on a review of this recommendation with the I believe it was an AFP article, they did review these recommendations and they did bring up this point for hyperlipidemia and non-alcoholic fatty liver disease. First line treatment is behavioral interventions already for those with obesity, and that's the first line intervention for hyperlipidemia as well. So they kind of raise the question, what really it would be the point of doing this screening if you're not going to change your intervention anyway? So you can keep that in mind, but regardless, this is the recommendation by the AAP in their guideline to screen for these conditions. I will throw out, I didn't list these on here, but I will throw out a couple other recommendations. These aren't their key action statements. These are just kind of general consensus recommendations. They recommend for any children with obesity, specifically those who are over 10 to 13 years of age, they recommend screening for things like OSA or hip issues like SCFE. Like the OSA, you would typically think to screen up for someone an adult with obesity. So you might consider to do that with children as well. Essentially, it boiled down to if you were considering screening it for an adult, you might want to consider screening a child for that as well. Now, moving on to the treatment. And this is where the majority of our presentation is going to focus today. Obesity is a chronic disease and should be treated with intensive and long-term care strategies. The first treatments I'm going to go through are probably what you're familiar with treating children with obesity. But I'm still going to go through them anyway, as maybe you weren't familiar with one or multiple of these different treatment modalities or options, and they might be able to help some of your patients. So, first of all, they recommend motivational interviewing, essentially helping the patient to choose how they're going to change, letting it become the patient's choice. And however you best use motivational interviewing, they recommend that you do that with these patients as well. Second on the list here, intensive health behavior, and lifestyle treatment. This is a very intense behavioral program that focuses on diet, exercise, and other lifestyle activities that the patients do, but it involves very frequent visits and follow-up with their team. As you can see here, a minimum of 26 hours of face-to-face, family-based, multi-component treatment over at least 3 months, but sometimes up to 12 months. This program, however, even though it is a great program and has shown a lot of success, isn't widely available. As you can see here, mainly only found in Washington, California, or Colorado. And there's very few online programs that are available. They aren't even close to equivalent. The closest thing we might have here in the Treasure Valley, though, is the St. Luke's Children's Integrative Medicine program. Again, no affiliation, no money I'm getting from this, but just want to throw it out there that from what I've seen, this is probably the closest program that we have in the Valley. And I've heard from at least a couple people some good responses to that program as far as managing weight is concerned. And then moving beyond that, the AAP article does recommend different diet and exercise strategies. And I'm going to go through a number of these because there's actually quite a few. And I will say up front that the AAP article recognizes that all of these have shown some benefit, but they don't clearly see one that sticks out as better than the other. So these are all available on the AAP article, but I'm going to go through a little bit of each of them here today. The first one is just kind of a general recommendation to reduce or remove sugar sweetened beverages. They have seen good weight loss with, or decent weight loss with removing sugar sweetened beverages in both adults and children. Um, a, Something to point out here is I'm sure we've all seen it in clinic, but a lot of times parents might not be aware that fruit juice is also a sugar sweetened beverage and can be just as high in calories as other things like soda. Maybe the only benefit would be a little bit of vitamins, but really, as far as weight is concerned, it's not going to be doing them really any benefit to be switching from soda to fruit juice. Um, should be trying to stick with low calorie beverages in order to have any of that weight gain benefit. Moving on, the Choose My Plate program. This is a U.S. Department of Agriculture program that makes recommendations for not just children, but adults for healthy eating. It goes through multiple different dietary goals, and it starts off with you can put in your weight and age, height, basically giving them your BMI with your age. And they give you calorie recommendations for maintaining or losing weight. Let's see here. Yeah, I have a little example of that here. This is from the Choose My Plate page. You go through and you can put in your information, oh, and your physical activity level. And then this was me. This is what I need to do to lose weight if I want to, per Choose My Plate. And then they give you a bunch of different fruit, vegetable, protein, dairy, grain options to choose from, and recommendations on how much of each of these you should be taking to get the recommended calorie requirements and keep up with your dietary plan. Another benefit from this is they also have different options that might meet different cultural standards. So uh, whether they're from Mexico or from Maine, they have different options that they might be more accustomed to that they can choose from. Moving on from that, there is this general consensus recommendation for 60 minutes of moderate to vigorous physical activity. Um, And I know for adults, we often say somewhere around 30 minutes. Kids are better than us, or I guess, or hope to be. And 60 minutes is what the recommendation is to see some better weight control and or weight loss. They also recommend or have seen evidence for HIIT training as well that can improve obesity. Um, and again, that's just kind of a general recommendation. Um, on the flip side of that, they recommend a reduction in sedentary behavior. Um, we mentioned how screen time has steadily increased for children throughout the years. Um, they have seen good evidence that reducing screen time and increasing activity time does help with weight. The AAP currently recommends or at least as of this guideline, recommended under age 18 months, no screen time, an hour limit for 2 to 5, and they didn't really give a limit for people beyond that, but they say non-excessive, whatever that's supposed to mean. But regardless, the gist of it is less screen time, more activity time, the better clearly it will be for your weight. Um, a few other recommendations or dietary lifestyle tips or tricks that they recommend. You They recommend avoidance of breakfast skipping. Now, I know that there has been a type of diet, the intermittent fasting, that some people have found success with, myself included at times. But it seems that from the evidence they've seen in children, a lot of times when children skip breakfast, this is more associated with overweight and obesity, and they suspect it's due to lower quality of dietary intake throughout the day, such as snacking, um, and just overall poorer qualities of food that they get in throughout the day. So, with your pediatric patient, if they are skipping breakfast and they're having trouble with weight, maybe consider recommending a hearty and healthy breakfast uh, instead of snacking. Um, the next possible approach that you could consider is called the traffic light diet. This approach is one of the approaches used in those high intensity programs, um, and it has shown some success. Basically, the idea behind it is you have a green light on types of foods that you can just eat as much as you want of. This includes in these categories fruits, vegetables, low fat milk, lean meats. They basically say go for it. Yellow foods are foods that should be eaten only sometimes, not all the time. That includes some more fuller fat dairy and whole grains and breads. And then red foods are the ones which they recommend rarely, if ever, eating. Those include desserts, saturated fats, carbs, things like that. So, um, anyways, the idea here is just to give kind of a visual to the children, help them make better choices with their dietary needs. Um, Another similar tactic that has been used is the 5210 model or the 95210 model. Um, with this diet option, it gives you recommendations on different types of foods and lifestyle choices that you should do associated with the number. As you can see here, 9 hours of sleep, 5 servings of fruits and vegetables, 2 hours or less of screen time, 1 hour of physical activity, and 0 sugary beverages. So that's the idea behind the model, put together by pediatricians to make a simple, memorable model for children to remember. However, to this point, we haven't seen great benefit with this, at least on the literature review. Though you could consider including it in part of your recommendations for these kids, as it is something that kind of stands out. And I know that you can get handouts of these at different children's clinics. You might have some in your own clinic. Um, Moving on from that, just kind of some general recommendations again. Oh, actually, this part is talking about screen-based physical activity. So, in the more recent past, they've developed screen-based activity games that might be on the phone. They might be on um, separate devices. They might be virtual reality-based activities. But there is some recommendations to consider encouraging this type of activity, especially if you're not able to get these patients to engage in activity in other ways. This is kind of an interesting compromise between the less screen time and more physical activity. Um, I can say from doing some virtual reality games myself that they definitely can, some of them can definitely get your heart rate up. But again, it kind of depends on what you choose and um, if the patients would be up to making this a regular routine. There is some potential benefit there, again, increasing the physical activity, but you might need to counterbalance that with the increased screen time that they could get from that. And then lastly here, this was a point that was kind of touched on in the 95210 model, but obesity is associated with shorter sleep duration. They think that might be due to uh, increased uh, calorie consumption, and decreased physical activity, changes in hormones such as increased ghrelin and decreased leptin, leading to more hunger. But regardless, they do see if they are sleeping less, they do have a risk for having more obesity. So getting that average of somewhere in the 9 hour range, obviously it changes based on age, but trying to get the recommended amount of sleep could be a potential option that you could consider for the treatment of obesity. Now, all that being said, I want to get now to the more interesting and kind of newer part of the guideline. Everything I've discussed up till now has probably in one way or another been sort of what we've recommended in the past. Change your diet, exercise more, get good sleep, you know, regular recommendations that we keep trying to make just in a little bit different new ways. Um, and a lot of times it's been kind of you make those recommendations, you watch and wait, and you come back a year later for their well child check, and you're surprised when they're still on the same line of the um, BMI scale. So, with that in mind, they have made new recommendations. Pharmacotherapy is now considered no longer something that should really be taboo in children or adolescents, and not something that should be restricted only to specialists. It definitely shouldn't be a monotherapy, but it can be used in conjunction with behavior and lifestyle changes. Mainly, it the guideline recommends consider use of pharmacotherapy for children that are older than 12 with obesity, but they also do recommend considering it for 12 and under if there's other indications such as diabetes, um, etc., for those children as well. So, with that in mind, some of the potential treatment options include things that we should likely be familiar with adults: metformin, orlistat, GLP-1s, phentermine and topiramate, either together or separate. And obviously that's not the entire list, but those are some of the options that they recommend we might consider. Um, Now, obviously for a good number of us, it could be a new or somewhat kind of scary thing to recommend in a child. Um, and there's no specific recommendations on when um, we might need to refer a patient. But if you personally don't feel comfortable prescribing these medications to a pediatric patient, you can always refer to obesity specialists or to like this program that they have at St. Luke's that could be a potential option. Um, because, and I would recommend that if you do have patients, children who are in the obese category, that you consider referring or making some intervention sooner rather than later, as this is kind of a compounding condition. And the longer they have it, the more likely they are to develop comorbidities. Um, Again, they also make a recommendation that PCPs should offer referral for adolescents 13 years and older with severe obesity. So it's that greater than the 120% of the 95th percentile. Refer them for evaluation for metabolic and bariatric surgery, um, ideally to a local or regional pediatric bariatric surgery center. Um, that could sound scary, but again, anytime we refer anyone to bariatric surgery, we know that they're not going definitively to always get bariatric surgery. There's always the assessment, evaluation, and they can sometimes get them into their more robust programs to help them with weight loss without surgery as well. So even if this family isn't 100% on board with surgery, I would consider making a recommendation if they are 13 and older, greater in that severe obese category range. Consider sending them over there just so that they can at least get some additional help and resources. Um, Now, I've already touched on this a bit. In the past, we've mainly focused on diet and exercise. But now the idea is that we should be viewing obesity as a chronic disease, somewhat similar to asthma and diabetes. And for people with asthma and diabetes, if they're children, we don't recommend just telling them, well, you should just watch your diet or make sure you avoid your asthma triggers. No, we give them medications that can help them manage their conditions as well. And kind of along those same lines, the new way to think about obesity in children and adolescents is to not only include the lifestyle and behavioral interventions, which we should include, but also to consider adding on some form of pharmacotherapy or bariatric surgery if indicated. Um, but obviously, especially in kids, you always wonder about the long-term effects because anything started at this age could have domino effect down the road. Um, the evidence that we have now, I'm going to present to you, and then we'll go through what we have and what we can't really talk about yet. For GLP-1 therapy, multiple studies have been done on adolescents and pediatric patients, and they've found, similar to adults, significant weight loss benefits. The side effects are also similar to adults, short-term GI side effects that were the most prominent. They did have a potential for increased gallstones with GLP-1 use, thinking maybe potentially due to rapid weight loss. And then there's also infrequent reports of mild hypoglycemic episodes. Again, somewhat similar to what we can sometimes on rare occasions see in adults. How about bariatric surgery? Well, looking at one study out of Sweden, they looked at Roux-en-Y gastric bypass in adolescents with severe obesity. They did have a few notable findings. Adolescents with severe obesity that underwent Roux-en-Y experienced substantial weight loss over 5 years, and they had improvement of their comorbidities, risk factors, and quality of life. They did have side effects, though. There was a concerning prevalence of iron deficiency, anemia, low vitamin D levels, suspected likely due to poor compliance with supplementation. And clearly that can happen in an adult as well, though of course you could be even more cautious in a child about compliance with medications or supplements. And then there was increased rates of repeat surgical intervention for hernias and need for cholecystectomy due to gallstones, also thought to be likely due to rapid weight loss. So these are some of the studies that have been done. Um, a different article brought up a few different points, though, that we might also consider apart from the side effects of these medications. And this is particularly related to GLP-1s, but you could also apply some of these to bariatric surgery as well. So the first point they bring up, does the use of GLP-1s for pediatric obesity treatment worsen or exacerbate existing health disparities? So in a nutshell, they suggest that based on a few studies, that while expanding obesity medication can lower the overall obesity rates in children and adolescents, it could also worsen the disparity between racial and ethnic groups, as these interventions, GLP interventions, obesity treatment, bariatric surgery, these are all going to be and are currently expensive treatments that likely wouldn't be available or not able to be accessed by racial minority groups that have lower socioeconomic status. So you could see a big disparity there where the more affluent group is able to become less obese, but the other groups remain just as obese as they were before. Um, Another point they bring up, might youth be stigmatized for using GLP-1s or bariatric surgery to lose weight? Um, they speculate that weight loss would likely draw attention from peers, which likely would. And that attention could be in the form of encouragement and praise or negative teasing. But they also mentioned that both of those could have a negative impact on the psychosocial health of the patient, um, in either case by not wanting so much attention. Um, and a number of other studies I'll mention here have shown similar things for people, for example, who get plastic surgery to fix deformities. While there's the definitely positive benefit of getting those deformities repaired, they also can get made fun of or feel embarrassed about having to have that procedure done to fix their problem. Um, and we also see that adults, even who tend to be less judgmental than kids, but not always, but even adults might be judged or are being judged for using weight loss, GLP or bariatric surgery for weight loss, kind of along those same lines of resorting back to you're being lazy, you're not having enough self-control. Um, and they also bring up the point that we also need to consider with adult patients. When you discontinue these GLP-1s, are you just getting a temporary fix that will promote unhealthy lifestyles, that will just worsen after they're stopping their medication? So these are counterpoints to what the AAP article recommends. But the bottom line is, as far as true long-term benefits or risks, we don't have that much direct data just because all of these interventions are relatively new, especially in children and adolescents. However, we do know the effects of obesity, and they're not good. So, because obesity is a chronic disease with escalating effects over time, As the article mentioned in the beginning, we should consider this as a life course approach. Essentially, if you would, I guess I would say the gist of this recommendation is to start considering. I know we don't want to look at everything this way in children, but you can kind of look at them, at least in this sense, as mini adults. So if you would consider using an intervention to help treat obesity in an adult, maybe consider using it in a child as well. Um, because one day they will be adults, and this is an issue that will carry with them and likely get worse, only get worse as they get older, as the predictive models have estimated. So this is a problem we should probably start addressing now rather than later. The practical side, will any of this get covered? I have no idea. I'm just giving you the recommendations. I know it's hard to get these weight loss interventions covered for adults that don't have comorbidities, and I'm sure it would be difficult to get some of these covered for pediatric patients as well. That doesn't change the fact that we should be considering these interventions and what's best for the patient. And with that being said, I want you to consider, how will this information or these recommendations change your practice? Or are you already using these interventions? If you are, I would, if anyone listening has been using some of these, especially medical interventions for children with obesity, I would encourage you to share here in the next few minutes when we open up. But in any case, I would encourage all of you to consider implementing these in your practices if you have pediatric patients as a part of your practice. Here are a few, well, basically all of the references. As you can see, there's numerous GLP-1 studies and bariatric surgery studies. PubMed has a great resource for a lot more than this, just the ones I pulled from. And with that, I will open it up for questions. Thank you.